It's Friday. It's noon. That means it's live with TOA. The doctor is in, or the doctor's in live with TOA. Hi, Stahlman here again. Thanks for being here. For those of you who've been affected by the tornadoes here in Middle Tennessee, our hearts go out to you. I hope you're doing okay. I've seen a few people who've had various degrees of injury, and if there's anything that TOA can do to help you, let us know. Obviously, we've got a new face here. This is Dr. Chris Anderson, and he's one of my partners here, and it's really a privilege to talk to him today about some new technologies. We talked about some biologic technologies and stem cells and mentioned PRP in a previous video. But Chris is kind of the man in the practice with regard to knowledge and experience with using PRP, and we'll tell you what that's all about, for treatment of musculoskeletal problems. So it's really a great, pertinent time to have him come in and talk to us. As with all of our videos, yes, I'm an orthopedic surgeon. Dr. Anderson's an orthopedic surgeon, but today we are not your orthopedic surgeons. Please remember that the information that we're going to talk about today is for education and informational purposes, some entertainment purposes, but this is not considered medical advice. If you have problems, if you have questions, please feel free to reach out to TOA, www.toa.com, where you can make an appointment. You can see what we're up to, see what we do and where our locations are, see what our physicians do to try to help take care of your problems. So let's move on. So Chris, thanks for being here. As with other interviews, I do not want to presume to give you the blurb about who you are. So sure. Do me a favor, why don't you just tell us all about you, a little bit about your background, what your interests are, that type of thing.
Sure. So my name is Chris Anderson. I'm a sports medicine specialist at TOA. I trained here at Vanderbilt for residency, and then after that I did a sports medicine fellowship at Stanford for a year and got some experience there working in sports medicine and hip arthroscopy. And then after my time in California, I moved back to Nashville and joined TOA, and I've been here for 6 years now. And since then, my practice consists of only sports medicine and also biologics, which is what we're going to talk about specifically today. But the majority of it is sports medicine, surgery, and hip arthroscopy. So, yeah.
Awesome. So you made the good segue. We're going to talk something about biologic treatment in musculoskeletal care. Give me a little bit of an idea what that means. What is that?
Biologics is the concept of using a material that's harvested or harnessed from your own body or from another human's body in order to attempt to alleviate pain and or help regenerate tissue. Theoretically, we can talk more about that, but that's biologics. It's using biological material from your own body or some other donor material that's used to try to treat some type of condition.
So cells, tissue, that type of thing, rather than man-made products like metal or plastic pieces, right?
Or even like corticosteroid injections, which are very common steroid shots that people get for arthritis and such, wouldn't be considered a biologic. It'd be considered a drug. And so it's cellular material or cells or tissue material.
So we're today going to talk about PRP. What does that acronym mean?
PRP stands for platelet-rich plasma. It's a biologic that's been around for a little bit longer than most people want to admit. It seems new, and a lot of people haven't heard of it before, but it's something that we've actually been using for quite a while.
So tell me about it. What is it? What does it do? Yeah. What do we hope to do with it?
Sure.
And then we'll talk a little bit about where we use it.
Mm-hmm. So PRP, actually, scientists, physicians first recognized PRP and the value of this back in the 1950s. And the first studies were published on it back in 2007, 2008, about 12, 15 years ago. And what it is basically is where we take blood from the patient's arm. We do a venipuncture like you would if you go to the physician's office. and you take that blood from their arm, and by using what's called a centrifuge, which is a machine that spins at a very high rate of speed, we're able to filter out the red cells and other cells and white cells, and able to get just a concentration of platelets and plasma from your bloodstream. And we're able to utilize that material to then reintroduce or re-inject it back into somebody's body to help with a disorder that they have.
So the platelet-rich plasma, PRP, what do we think it's doing? How does it help?
Yeah, that's a great question. That's probably the most important question you could ask is why does this help? What we have to have when we're doing these things, I think it's important to have an understanding of the basic science on the molecular level, what's happening here. It's not good enough just to give it to somebody to see if it works. We got to understand it a little bit better, and this is something that's actually been studied in what I would call bench side research or basic science research, where they look at studies that are done in laboratories of why this actually works. And it's quite interesting. There have been a lot of research done on this over the years, and what the general consensus is that the platelets have growth factors and signaling agents in them that when you introduce that to a cell or some type of other part of the body, the platelets have been shown to release those growth factors and can actually alter the inflammatory mediators that are secreted by that part of the body. For instance, if somebody has arthritis and they've got inflammation in their knee, by introducing platelets, theoretically what's happening is the platelets are releasing growth factors, and they're telling those cells in the knee that are inflamed to calm down, to decrease the inflammatory response to the arthritic process. And by doing so, we think that improves the pain.
So you're primarily, I guess, it sounds like it's a inflammation fighting tool. Is that right?
This is in particular, and that's important to have a discussion with your patients about this, because we don't have clinical evidence that this stops the progression of osteoarthritis or improves somebody's osteoarthritis or regrows cartilage. We don't have that data. This, we think, more than anything, is more of just an inflammatory thing. So by doing this, we're actually, it's been shown that, for instance, if you take a culture of cartilage cells and you bathe them in PRP, it actually changes their genetic expression of certain proteins that are pro-inflammatory. And in lieu of that, it converts them to more of an anabolic state or anti-inflammatory state, which decreases the inflammation. So that's what this is really all about. It's not necessarily about regrowing cartilage. It's more about inflammatory changes and pain.
So that's an interesting you bring that up, because one of the things that I've read in the common literature, magazine ads and such like that, people are promoting various, and sometimes it seems like they're throwing a lot of things into one basket and kind of making them all sound the same, of growing cartilage or renewing your joint that's worn out. And that sounds like that's not exactly what we understand this particular technology is all about, right?
That's correct. Two very important points here. One is the amount of misinformation out there is staggering, and we're getting multiple different treatments getting dropped into one bucket, in the biologics bucket, and it gets very, very confusing when you do that, because a lot of times we've got many different treatments that are somewhat similar, but just different enough to where they're not really comparable. They're maybe comparing apples to oranges, or even worse than that. And so, yes, that's a very confusing thing. And what was the second? Yeah.
I think you pretty much cover that. Yeah. So so give me a little bit of an idea of, since I'm a spine guy, you can't really PRP joints in the spine very easily anyway. In your practice and in your experience and in your review of what's out there, where is PRP used? What part of the body? And what seems to be its best location for use? Where would you advise people to have PRP treatment?
Right. Yeah. I mean,
introduced.
The PRP has been used virtually everywhere in the world, and that's one of the problems. It's almost like the usage of it and how commonly it's used preceded the actual data that supported its use in particular areas, and so if you look at the research, I mean, we're as orthopedic surgeons, I think we owe it to ourselves to be research-oriented individuals and use scientific evidence to guide our principles of how we treat people. And if you look at the research on this, the clearest indication we have right now is knee osteoarthritis. It has been studied in numerous areas in orthopedics all over the body. There's lots of active research going on right now. There's over 100 clinical trials registered right now with the NIH on PRP for musculoskeletal conditions. And so, but right now, as of right now, what we have is pretty good solid evidence, including randomized trials and meta-analysis of randomized trials for knee osteoarthritis, showing that it can benefit people in terms of pain reduction relative to a placebo or relative to other available treatments out there. Such as hyaluronic acid, the gel injections, or corticosteroids. Even there's been one study looking at ozone injections. But the mainstay, the cortisone injections and the hyaluronic acid, it's compared against those and placebo and showed to be better. And then, I think randomized trials are necessary, but once you develop enough of those, you need to really pool together the best randomized trials into a meta-analysis. And that's where they take every patient from all those trials and they pull them into one big data set, and then they do another comparative analysis of the data and find out whether it's really actually accurate or not, if that treatment is working. And there have been several meta-analyses done, and they're all showing the same thing, which is PRP is more beneficial compared to the other treatments. So that's very promising for knee arthritis. There are some active studies, or have been some studies published for hip osteoarthritis as well. Not as many as the knee literature. There's been, according to my last research review, I found 19 randomized trials. There have been at least 3 randomized trials done for hip osteoarthritis that showed they mirrored the same kind of outcomes that we saw in knees, that it does show benefit. And so I think for the osteoarthritic conditions, that's really the mainstay of treatment for PRP. It's been used for tendinopathies like tennis elbow, patellar tendinopathy, Achilles tendinopathies, and then it's even been used for surgical things like meniscal repair, ACL reconstruction, rotator cuff repair. And the data on all those other treatments is really, it's really unclear at this point how much effect it has and what effect. And part of the problem is there's so much heterogeneity in these studies. They're using different types of PRPs. This study used this type, this study used this type. They treated different patients with different conditions. And so it's making it really hard to filter through all that variable information and know exactly if it's having an effect or not.
Yeah, and that's what I found in spine in particular. Yeah. One of the areas that people theoretically use PRP is intraoperatively. Yeah. To somehow or other affect wound healing. That's the theory that they're going behind, but it's completely not supported by any strong literature or studies. And so right now, anyway, we're kind of in the heyday again of lots of hope, lots of technologies out there, limited amount of data. And I'm like you, it only makes sense to offer treatments that can be supported by data in the mass population.
Yeah, they have to.
Until you get those patients, you want to experiment and try and see. But once you get numbers, then it really makes much more sense to say, okay, I can support this.
Yeah, I think we just owe it to ourselves. This stuff, any treatment you give somebody has to be supported by basic science and clinical research. There's a systematic approach to this. And it's been done this way since medicine has been created. You start with basic science studies, whatever it may be, and then you eventually translate that into a clinical study. And now part of the problem with biologics, Gray, is that we're seeing this kind of reversal of that system that's been upended a little bit, and you're seeing this direct to consumer marketing. You're seeing this social media, internet kind of access where people have unlimited access to information, and they know about the treatment before we've had time to even vet it and determine what it's useful for. And it gets confusing, and I think for those reasons, people do need to discuss this with their physician. The physicians need to be honest with their patients and give them clear and accurate information before we start just treating everything with this. Because next thing you know, you can start treating people for things that it doesn't help them, and we don't.
Yeah, that's kind of I like your the upside down approach thing there. It's almost like we're back in the 1800s with the snake oil salesman. In some regards, with regard to biologics as a whole.
That's correct.
So in your practice, you mentioned steroids. You mentioned viscosupplementation, hyaluronic acid. You mentioned PRP. Tell me a little bit about your thought process about, okay, who would you recommend this for and when? In their process of my knee hurts and I've got some arthritic change.
Yeah, I mean, in a perfect world, if somebody has mild to moderate osteoarthritis, in a perfect world, if insurance aside, money aside, I would probably treat every patient that came into my office with PRP.
Really? That would be your primary treatment? Interesting.
In a perfect world, without any, you didn't have to worry about money, insurance, anything, because the data's there. I mean, granted, we don't have 100 randomized trials. But 20 is pretty good, and meta-analysis on top of that is pretty solid. And so the results are good, and the data is very convincing. I mean, for instance, the steroid injection really is a very transient effect on most people.
How long would you guesstimate?
If you look at the data, really, I mean, 2 to 4 weeks is what the data suggests. I mean, that's not a very good result if we really think about it. And that's been the mainstay of treatment, conservative treatment for osteoarthritis for generations. I mean, and then if we compare that to PRP, for instance, PRP has been shown in numerous studies to have a much more lasting and durable effect that is more pronounced and lasts longer than the other available treatments. I've got some graphs here if you want me to.
Yeah, that'd be great, because I'd love to know kind of the difference between, because what people really want to see is, I want it to last as long as possible. And give me the best effect.
Yes.
And it sounds like you've actually got that information that we now have 2 or 3 things to kind of compare to.
These are both from published randomized trials. This is a study that looked at PRP compared to hyaluronic acid, which is the gel injection we do on people. And if you look, this is starting at time 0. This is called the IKDC score, which is a score that is an International Knee Documentation Committee, and it rates how functional their knee is, basically. And most people are down here. And as we do the injection, you see both people kind of transiently go up. The PRP is this darker line right here. It goes up higher, and then it stays up higher, and even at 1 year out. Whereas the cortisone injection went back down to nearly baseline again. The PRP is still higher. That's statistically significant at these levels here.
So you're looking at an improvement in your knee score of 50% or greater, essentially, from the baseline, and it's staying there.
And staying there for 12 months. And this has been mirrored in almost every study that's been done. It shows that. This one is another study. This was an FDA-sanctioned placebo-controlled trial, which means they compared PRP to a saline injection. The people that did the injection and the people that received it were both blinded. Neither one of them knew what they were giving or knew what they were getting. So this is probably the most valid way to research this.
And the hardest kind of study to do.
Hardest, very difficult study to do. So I applaud these people for doing it. This is looking at a different score called the WOMAC score. Lower in this chart is better. Okay, higher is worse. The blue line right here this is ACP, which is a proprietary company's version of this. They all started out, pretty high, but the ACP went down, way down, and at 1 year, again, it's lower than what we saw with the placebo, which was saline injection. So we know that it's better, according to these studies, than the available treatment. So in a perfect world, I would use that as a primary treatment on somebody, but we don't live in a perfect world, obviously.
So you mentioned, and this is part of the non-perfect world, you mentioned the whole money aside, insurance aside. So give me the skinny on that.
Well,
is PRP covered by insurance?
Yeah, and PRP is not covered by insurance, despite the mounting body of evidence that suggests that it's effective treatment. They have classified it as experimental, and I'm not so sure that that's ever going to change. I don't know what it's going to take to change their opinion on that, because if you have dozens of randomized trials and studies that actually suggest that it works, and they still claim it to be experimental. I don't know what their definition of experimental is at that point.
It does get kind of frustrating. I deal with certain procedures in the spine where for years and years and years it's been considered investigational or experimental. I think there is some hope, and I think with a mounting pile of good data, and a mounting pile of, in my opinion, more good data that suggests that the others are really not that great.
Right, that's right.
Then it will kind of bubble up to the surface.
Yeah,
and
that's the thing is we have again 100 trials that are registered right now in PRP for knee arthritis, and we have for the hyaluronic acid, for instance. We all know the data there is very
well, it's gotten sketchier over the years too.
Yeah,
right?
and even to the point where at one point the AOS, our American Academy of Orthopedic Surgeons, which is the largest academy in the entire world for orthopedic surgeons to be members of, had classified it as they could not recommend for or against the use of hyaluronic acid for knee osteoarthritis.
Yeah.
So you're exactly hit the nail on the head. The other treatments available are not that great. I mean, corticosteroids do have an effect, we know, but they're very fleeting, 2 to 4 weeks. And hyaluronic acid seems to work sometimes, but other times it doesn't, and we can't quite understand that. And then, both of those are approved by insurance, but PRP isn't. And so, my current algorithm, back to that original question, somewhat depends on the person, how bad their arthritis is. If they've got end-stage arthritis or bone-on-bone, they're probably not good candidates for PRP.
For anything.
They really just need a knee replacement,
right.
probably, if the time is right and the pain's severe enough. So those people, if they're trying to buy time or they've got a vacation coming up, we'll do a corticosteroid injection just to buy them a little bit of time to get them through a certain time period in their life. If they don't want to spend the money on the PRP and they're have good insurance that will cover hyaluronic acid, I think it's not unreasonable to try, and I give them my full disclosure, which is I don't know if this will work or not. I think it's worth trying. If it works, great. If it doesn't, I would move on from there. And then, having said that, if somebody just automatically wants to spend the money on PRP and they understand it's going to cost them out of pocket and it doesn't go towards their insurance deductible, and they understand we think it's a better treatment according to the evidence at least, I offer that as well. So I'll sometimes offer people that and see what they say, and if they want to do it, then we go ahead.
What's the ballpark cost out of pocket?
It's right now it's $550 per injection, and so that ends up being, we do once a week for 3 weeks. It's a 3-part series, and that's based on evidence. There is some evidence that suggests that 3 injections is better than 1. That is still yet to be kind of more studied, but we do think that 3 injections has a better effect than 1. So we do it once a week for 3 weeks.
So a treatment regimen, 1,500 to 2,000,
something like that.
Well, in my experience, when hyaluronic acid came about, so I'm a little bit older than you are, and so when I started in practice, we didn't have anything else but steroids.
Yeah.
And then viscosupplementation hyaluronic acid came out, and it was $700 to $1,000 for a 3 injection. Prescription, and it's probably a little bit less because now there's some generics, but that seems very in line with recent trends over the last 25 years of change. So
and we don't know how this is going to end up yet. I mean, the thing is hyaluronic acid at first looked very promising, and then over time the studies became more and more kind of, some showed effect, some did not show effect. And whether history is going to repeat itself and show the same thing for PRP is yet to be determined. And we may be, in 15 years from now, look back and go, hey, wait, maybe PRP didn't work as good as we think it did. But I will tell you that based on this current evidence, it's encouraging. And, I mean, the clinical evidence, my own experience has been encouraging. So, I think it's...
Now, people are worried about, when you first introduced yourself, you talked about biologics being cells or tissue from either your own body or somebody else's body. And I just want to be clear, this is coming from the patient's own body.
That's correct.
So there's no risk of rejection of this material.
That's correct. And no risk of allergic reaction or other things that you see, like for instance with hyaluronic acid, people have allergies to eggs can have an allergic reaction to it. There's no risk of that, so it's safe, and there's been lots of safety data on this that has shown really the only reaction people have is pain. There's really never...
Because of the injection?
Because of the injection, probably. And maybe because the platelets themselves have some biological effect that triggers a pain response. It's unclear. But yeah, so how we do it, and I brought a little prop here to show everybody. This is the typical syringe that we use. And we, again, do the venipuncture, get the blood, and pull it back into the syringe. And then from there, so it's all in this self-contained system. And then from there, we cap this, and we put it in the machine, and that spins it down very quickly. And it creates a layer of blood cells on the bottom and platelets on the top. And I've got a picture here I wanted to show everybody what that looks like. And so you can see here in this picture, this is the syringe. Now you've seen the red cells are down at the bottom, and we use this second syringe that's inside the first one to siphon off the platelets from this concentrate down here. And so we've got plasma and platelets right here. This gets uncoupled and we inject it directly in the body. So it doesn't ever go anywhere else. It doesn't go to a lab. It doesn't go to another facility. It goes from the body to the syringe back to the body again. It's all contained.
All in their
It's
office.
all contained.
Yeah, cool.
So
I guess really the only true risk for people is the very small chance of infection just because you're introducing a needle into the body. Is that correct?
That's correct. I've never heard of a case of that, but that is a theoretical risk of this. Yes, and pain.
Awesome. So in closing, this has been a fantastic talk. I mean, I've enjoyed watching you kind of grow with this technology because you've been doing this now for more than anybody in our practice over the last few years. And I love your scientific methodology. Your brain works like mine does. I want to see the data. I do stuff because I can back it up. And that's always been my frustration with the, again, direct consumer marketing, the huge industry of, so this is my soapbox, regenerative medicine, that people are preying on people's hopes and dreams. Something may come out of some of the technologies they use, but it does bother me some that in that basket of regeneration is a technology that really doesn't regenerate, but it is a really appropriate way to manage symptomatic arthritis of the knee. And that's what we're trying to do, is manage symptoms. And we avoid surgery. That would be awesome. Are we making the knee joint better than it was? Well, mechanically, no. But symptomatically, maybe.
Yes.
Anything else you'd like to mention? At this point, this is the time to sell yourself. You know, is there any information that people might be able to find online, either from you or from someone else that you would trust, that you could direct them to? We can also, if people have comments online, please feel free to comment. We will address those comments. We can give you resources and stuff like that if you'd like. Anything in closing?
I just wanted to, the last thing I wanted to say is that if you have questions about this or confused, talk to your physician about this. There is so much misinformation out there online. It's almost just profound. And I talk to people daily that read stuff online or talk to people who aren't physicians that are doing various injections on them. And there's just this tremendous amount of confusion, especially with this so-called stem cells that people are giving. We have to be just extraordinarily careful of how we discuss this with patients and accurate with what we're telling them. And I would just caution everybody, talk to your physician about this. In the United States, currently, there are no FDA-approved stem cell treatments for knee arthritis. If somebody's telling you they're giving you stem cells in your knee, that's incorrect based on the definitions that have been laid out by the International Society of Cellular Therapy, which clearly states that stem cell treatments is when you take a stem cell from your body, you grow it in a lab in a monoculture, you test it to confirm that it's a stem cell, then you re-deliver it back into their body again. The FDA in 2001 passed laws that made that process illegal in this country. That is being done in other countries, and with some early studies showing success. The stem cells that we have in this country are really not stem cell injections. They should be defined as what the International Society of Cellular Therapy is defined as a cell concentrate injection. They take cells from your body that have some stem cells in them, try to concentrate them, and then re-inject them back in your body. The most that they can concentrate those is usually around 1 or 2% of the total concoction. And I tell my patients, I say, hey, listen, if I ask for a glass of orange juice and you bring me a glass of water, with a few dashes of orange juice in that. Is that a glass of orange juice?
That's
And
great.
the answer is no, it's water with some orange juice in it.
Right.
And so, we have to be very careful. I hate to see people spending lots of money on things that have not been tested, that have not been studied well, like PRP has. And, we need evidence before you make this leap into doing a treatment that is not even proven yet. And so it's extremely important to be vigilant of the data as it comes out. Know what you're doing. Talk to a board-certified orthopedic surgeon about this. Most importantly, a board-certified orthopedic surgeon is the only one, in my opinion, that can make these decisions appropriately. And eventually, we may see something come of all this stuff. We may see a revolution of biologics that enhance people's lives, that maybe even regrow cartilage one day. We don't know, but we're not there yet. And so we have to be very, very careful. We have to be ethical with what we do here. And that's I think the most important thing is you need to let your ethics override the temptation to just do things to people that are unproven.
Thank you for saying that. In our previous discussion about stem cells and biologics in the spine, in my world, there's really only two justifiable, studyable stem cell treatments currently in spine. Well, spine is for spinal cord injury and trying to regenerate spinal nerve, and the other is for blood cell cancers. Stem cells are useful for that. But like you say, what you're dealing with in those particular cases is not maybe some stem cells in a concoction of other junk.
Right.
It's stem cells cultured, verified, and it's a much bigger deal. And again, in your situation, again, people seem to be lumping PRP, stem cells, fat stuff, whatever else into this regenerative medicine thing. And unfortunately, I'm glad you brought this up, and I'm just going to say it. I'm fearful that our patients are being taken advantage of by certain practitioners offering theoretic treatments without data in a world that's not in a world where people understand this. Orthopedic surgeons understand cellular biology of the joints.
That's correct.
Unfortunately, people such as chiropractors do not. And so I think that's very important to understand. I mean, when you're talking about a stem cell treatment, and I've had patients who've come in and said, he offered me stem cells, and it was $5,000 for a treatment that's not based in anything. That's really bothersome. And so it's, again, preying on people's hopes and dreams and wishes and everything short of, and I think that's unfair. So I think Dr. Anderson's absolutely correct. Seek out a board-certified orthopedic surgeon, particularly somebody who is very versed and informed about biologic treatments for, in this particular case, symptomatic knee arthritis. Go to the specialist. Don't go to random Joe down the street who you saw an ad in the airline magazine, because you're not going to get what you need. Okay? Chris, thank you.
Appreciate it.
I'm not supposed to shake your hand.
There you go.
Chris, thanks again. Next time, we're going to be meeting with another partner of ours, Dr. Rob Greenberg. Dr. Greenberg is essentially a general orthopedic surgeon, but we're going to be talking about knee arthritis, and he has some more advanced experience in particularly using what's called the Mako robot, which is a surgical assistant to help do more precision joint replacement for the knee. And I'm going to talk to him about that. I'd like to remind everybody that TOA is available, www.toa.com. Do you have a personal website?
No, I don't.
Okay.
Yeah.
Dr. Anderson's bio and everything is on the website. Look it up. He's primarily based in our St. Thomas West office, but you also go to Dixon and Cookville?
Cookville, Dixon, and Mount Juliet.
Holy smokes. So he puts mileage on his car.
Yeah.
He's young. Last thing I want to just, in this time, I want to make sure people really remember This coronavirus, COVID-19, is a real problem. I think there's a lot unknown about it. It is not the flu, okay? It's a virus. It's not the flu. We don't know everything about it. Don't panic. Do smart things. Wash your hands. Don't touch your face. Stay out of big crowds where people can spit on you and cough on you. Stay away from people who are sick. If you are an older person or a sick person, if you develop a fever or a cough and achy pain in your body, go to the local medical facility and get tested. Testing is going to be coming around more and more in the United States. We're kind of lagging behind some of the other countries. But this is a big problem that we don't know a lot about. So just be smart, but don't panic, okay? Anyway, until next time, we'll see each other next week, noon, with Dr. Greenberg. Until next time, go out there and live your best life.